there. I thought I would just jump on today and just give you a little talk about the difference between nasogastric tubes and PEG tubes, okay, or G tubes. A nasogastric tube is a tube that is inserted through the nose, okay, and it is all the way through the nose, down through the back of our throat, into our esophagus, down into our stomach. Okay, and this is a tube that is placed sometimes by the nurse in the clinical setting. Usually more in a hospital setting, we would put down an NG tube. We're going to talk about the reasons for this in a moment. However, that is different than a PEG tube or a percutaneous endoscopic gastrostomy tube. A PEG tube is inserted surgically directly through the abdominal wall and into the stomach, and it is anchored in there with a balloon. And we can access this from outside of the body so that we can feed the patient enterally. And what this means is, and we can do enteral feedings either with an NG tube or with a PEG tube or a G tube. So we're going to talk a little bit first though about our NG tube. An NG tube is more of a temporary way of giving bowel rest. So a nasogastric tube is indicated for the following reasons. We might put an NG tube down when our patient has a bowel obstruction, meaning that there's an obstruction in the bowels, and so things are not moving through the intestines and out the other end, right? And so if that's happening, then gas, air, liquid, mucus is going to be collecting in the stomach. The patient is going to become very distended. They're going to feel nauseous. They're going to be vomiting. They're going to come into the ER and say they haven't been able to eat for a few days because they've completely lost their appetite. If we identify that they have a bowel obstruction, we're going to put an NG tube down for what we call decompression, meaning that we can pull off the excess air and the excess gastric contents that are building up in the stomach. And you can see here that this NG tube is connected to wall suction, so that it is very gently pulling that excess air and fluid out. We can also use an NG tube in the treatment of our patients with a prolonged ileus. Now, an ileus, it occurs sometimes after surgery when the bowels will stop working. And so the bowels will just kind of go into shock and they won't be functioning. So we won't hear any bowel tones. The patient won't be passing any gas or having any bowel movements. And again, we'll have to place an NG tube down during the time that the ileus is taking place. Sometimes the bowel obstruction will be relieved on its own. The ileus will go away on its own. The patient will start passing gas again, having bowel movements. We can remove the NG tube and we can discharge the patient. The other time we might use an NG tube is for bowel rest after surgery, or in the case of pancreatitis. If a patient comes into the hospital with pancreatitis, they will often get an NG tube placed to rest the bowel. And so the nasogastric decompression improves the patient's comfort. It minimizes and prevents recurrent vomiting, and it serves as a means to monitor or progress, to monitor the progress or the resolution of any of these conditions, okay? So that's what an NG tube is. We might use an NG tube while the patient's in the hospital to give them medications or to give them oral contrast for a CT. We might, again, use this for enteral nutrition if we have to deliver food via gastric feeding into the small intestine. However, I want you to keep in mind that if we ever have a patient connected to wall suction and we have to give them medication in their NG tube, we have to make sure we disconnect them from the wall suction, give them their medication in their NG tube, wait about 30 minutes, and then we can connect them back up to the wall suction. Otherwise, we're just going to put the medication down, and then the wall suction is going to suck the medication right back out of their stomach, okay? So that's an important thing to remember when you have a patient with an NG tube. All right, so let's take a second here to talk about PEG tubes. These are the tubes that are inserted percutaneous. And anytime we hear the word percutaneous used, what we're saying is through the skin, through the skin. So the feeding tube passes through the anterior abdominal wall right into the gastric cavity. This is more of a long-term tube that is placed by the surgeon, and it's utilized for patients who require long-term enteral feedings. This could be a comatose patient who's on a mechanical ventilator in the ICU, maybe with a severe head injury. This could be for patients with a neuromuscular disorder like Parkinson's disease or after a stroke where they need a PEG tube because they're not able to swallow. It could be used in severe anorexia from chemotherapy, HIV, or in sepsis. It could also be used in conditions associated with increased metabolic and nutritional demands. So again, like in the case of sepsis, for our patients that have cystic fibrosis, and in our patients who have suffered from burns. It's also used sometimes in our patients with cognitive disorders, like dementia, for example. So enteral tube feedings indicated when our patient cannot maintain adequate oral intake of food or the nutrition to meet their metabolic demands. And nurses commonly use enteral feedings in our patients with dysphagia. Patients with dysphagia sometimes cannot meet their daily nutritional needs, and so we have to turn to alternative means, and this is kind of what it would look like. There's a special type of a G tube that is used, or a PEG tube that's connected to some tubing, that is connected to a pump, often referred to as the kangaroo pump, which delivers the enteral feeding directly into the patient for a certain period of time. Sometimes this will run during the day, and we as nurses always need to make sure we're checking for residual. Checking for residual means that we're using a syringe to pull back on the PEG tube and make sure that there isn't a large amount of tube feeding that isn't being absorbed by the stomach. Because if that happens, we know that our patient, again, could be at risk for aspiration. What that means is if too much of the tube feeding is in their stomach and it's not moving through the small intestines and the bowels, then they have a risk for aspirating that tube feed up into their lungs and again causing pneumonia. It's about 25 kilocalories per kilogram per day, which is the energy requirement that our patients need. And this is always determined by the dietitian in concert with the physician and the rest of the team to keep our patients well nourished. So that is all I wanted to cover in this short section for you. And now you know the difference between an NG tube and a PEG tube. I hope you have a great day.